I'm Bob Sanders. I'm president of the association. Our first speaker of the day is Dr. Aliya Khan. Aliya Khan is a professor of clinical medicine at McMaster University, director of calcium disorders clinics, and fellowship in metabolic bone disorder at McMaster University. She graduated from University of Ottawa Medical School with honors and completed postgraduate training at the University of Toronto. She has published over 200 scientific papers and numerous chapters and books on osteoporosis and parathyroid disease. She has received numerous national and international awards, including the Queen's Diamond Jubilee Medal for Excellence, International Hypoparathyroidism Award, International Osteoporosis Foundation Award for Publishing Excellence, and recognition or recognized by Osteoporosis Canada for outstanding contributions to research and education. She was recognized as being in the top 0.1% of the world's experts in hyperparathyroidism by Expertscape. She most recently led the development of the new global guidelines on hypoparathyroidism that have just been published in the JVMR journal of October of 2022. And with that, I'd like to welcome Dr. Khan.
Thank you so much, Bob and Patty. It really is my pleasure to be here today and to share what's new in the diagnosis and management of hypoparathyroidism. So I'm just going to pull up my slides. And I really like the idea of hope that Patty emphasized, because there's a lot of hope. There's a lot of brightness down the road, and we really feel that we're going to effectively treat hypoparathyroidism and make this a condition that is not going to impact life in the future. So I'd like to begin with my disclosures. I have received research funding from a number of the industry partners for the development of new molecules for parathyroid disease. And we're going to talk about how to diagnose hypoparathyroidism, how to evaluate individuals who have this condition, what are the complications of hypoparathyroidism, and what are the treatment options that we have available today and are coming up. And we also will have a little bit of time to talk about the genetic evaluation of this condition and also what happens in pregnancy, because we have a number of patients, young women who are pregnant and they have this condition, and how should this be managed in pregnancy. So I will say a few words about that as well. And then, as Bob and Patty mentioned, there will be opportunity for questions. So I wanted to begin with a little bit of physiology. How do the parathyroid glands function? And basically, the parathyroid hormone is the main regulator of blood calcium, and every single cell in our body needs calcium to function. So when our blood calcium goes down, this is sensed by the calcium sensing receptors, which are sitting on the chief cells in the parathyroid glands. They're also in the kidney. They're also in other tissues as well. And when the blood calcium goes down, the parathyroid gland starts to produce more parathyroid hormone. So you can think of these receptors on the parathyroid glands like thermostats. It's like a thermostat. And actually, this calcium sensing receptor is called a calciostat because it functions like a thermostat. So when the temperature in our house goes down, it's sensed by the thermostat, and the furnace starts to work and produce heat so that the whole house will heat up. And so what happens is, if we don't have enough parathyroid tissue or the receptors aren't working properly, then there will be inadequate calcium levels. And the reason why parathyroid hormone is able to bring that calcium back up into the normal reference range is because it brings back the calcium that we would normally eliminate through the kidney. So every day, if we take in a gram of calcium by mouth, what enters our bloodstream is approximately 400 milligrams is coming in, and we excrete 200 milligrams, so about 200 milligrams. And then 500 milligrams goes in and out of our bones, but we put out through the kidney 9.8 grams. So if we took 1 gram, we're going to pee out close to 10 grams. We're going to pee out 10 grams of calcium through the kidney and reabsorb 9.8 grams. So 10 times the amount that we are taking in orally is actually peed out through the kidney, but then we reabsorb all this calcium. So we're putting out 10 grams, bringing back 9.8 grams, and we eliminate through the kidney 200 milligrams. And that was what we absorbed. So we're absorbing about 200 milligrams and we're peeing out 200 milligrams, so we're in balance. That happens if we have normal parathyroid function. That happens if we're taking in a decent amount of calcium and if we have normal vitamin D levels. Now, what if you don't have normal parathyroid function? Then what will happen is that we're not going to be able to reabsorb all that calcium. And we're going to pee out a lot of calcium through the kidney. And the reason why I talk about these numbers is so that you can appreciate how much calcium we could potentially be losing through the kidney. If we're taking in 1 gram or 1,000 milligrams and we're peeing out 10 grams or 10,000 milligrams, that's a lot of calcium that's going out. And parathyroid hormone helps us to reabsorb that calcium. And if we're not able to do that, the calcium, as it's being filtered through the kidney, will damage the kidney. And it will cause calcification in the renal tissue. We call that nephrocalcinosis. It can cause kidney stones to develop. And it can damage kidney function. So this is why parathyroid hormone is essential for normal kidney function, because it helps to bring that calcium back in. Another important point to remember is that parathyroid hormone activates vitamin D. Because if we look at, actually, I don't have a slide about the vitamin D here, but if we look at vitamin D is formed in our skin with sunlight exposure. We can also take precursors of vitamin D through food, and then vitamin D is activated. It's activated through the liver and it's activated through the kidney. And parathyroid hormone enables us to do the final activation of vitamin D. So people who don't have enough parathyroid hormone are not going to be able to form active vitamin D either. And that means that their ability to absorb calcium and phosphate from the bowel, this coming in from the bowel into our bloodstream, is going to be impaired. So if we don't have parathyroid hormone, not only are we peeing out all the calcium through the kidney, but we're also not able to absorb adequate amounts of calcium and phosphate from the bowel. And another feature of parathyroid hormone, these are the 3 main effects of parathyroid hormone, is that parathyroid hormone binds to the parathyroid hormone receptors on the osteoblasts, and these are the cells that make bone, and it causes the release of a signaling protein that activates the osteoclasts. And then these osteoclasts are going to start removing bone. They're going to demineralize that skeleton and dig holes in the bone and release the calcium that's stored in our skeleton, because our skeleton is really the bank for calcium and phosphate and magnesium too. So it's the bank. So if we don't take in enough calcium, or we don't have enough vitamin D, or we have malabsorption, parathyroid hormone goes up and says, no problem. I'll still be able to keep that calcium in the normal range. I'll just bring back more calcium through the kidney. I'll activate more vitamin D so that we become more efficient in absorbing calcium from the bowel. And I guess we'll just have to take calcium out of the bank. We'll have to take it out of the bones. If you have always very high levels of PTH, that will cause osteoporosis and demineralize the skeleton. But intermittently, we should be able to take calcium in and out of the skeleton. That's the bank for the calcium. But if you don't have PTH, then we cannot get the calcium out of the bones. And one of the important features of 125D when vitamin D is activated is it also helps to get the calcium out of the bones. And so someone who doesn't have parathyroid function will lose calcium through the kidney. damage the kidneys in that process with all these huge amounts of calcium being lost through the kidney, not have enough active vitamin D to absorb calcium and phosphate from the bowel and to get calcium out of the bones, and will not be able to access their calcium in the skeleton. And that will result in a fall in blood calcium. And that's a big problem. It's also important to remember that magnesium will interact with the calcium sensing receptor. And it also can have an effect on the tissues. And it can make the tissues, if there's inadequate levels of magnesium, it can make the tissues resistant to the effects of PTH. And magnesium can go down for many reasons. Some people who have problems with calcium can also have problems with magnesium. So people who have activating mutations of the calcium sensing receptor can lose calcium through the kidney. They can also lose magnesium through the kidney. With excess alcohol, there can be magnesium loss, malabsorption, diarrhea, diabetes, drugs like diuretics, proton pump inhibitors, tacrolimus, and other conditions can cause magnesium levels to go down. So when calcium is not normal, we have to make sure that we check magnesium and correct it, because the calcium and magnesium homeostasis, they're linked, because calcium and magnesium will have effects on PTH release, the parathyroid hormone release. So how do we make the diagnosis that someone has hypoparathyroidism, which means they don't have enough parathyroid function? Well, we look at the blood calcium, and remember that calcium binds to albumin. So your doctor may have checked your calcium and said, your calcium's fine. But did they check the albumin and correct for the albumin? Maybe they did, maybe they didn't. So it's important that we always check the calcium for the albumin, or check the ionized calcium, which is the free form of calcium. And we also check the PTH. So if someone has a low calcium, their parathyroid hormone should be high. It shouldn't just be normal. It should be high. It's like if the temperature in your house is low, your furnace should be on. It should be running over time to bring that temperature back up. If the furnace is off and the temperature is low in the house, there's a problem. Maybe you don't have a furnace. Maybe it's damaged, or it died on you. Or maybe the thermostat isn't working properly. It's not sensing the temperature properly, but there's clearly a problem. So in the same way, when we make the diagnosis of hypoparathyroidism, we need to know, what is the blood calcium doing? And what is the parathyroid hormone doing? If the blood calcium is low and the parathyroid hormone is not elevated, then that person does not have adequate parathyroid function. And it could be for many reasons. And we do want to check that twice to make sure that we have the right diagnosis. And we will check that. And we also look for other features of inadequate parathyroid function. One of the other effects of PTH is that it gets rid of phosphate through our kidney. So if we don't have enough parathyroid hormone, the phosphate levels start to rise. And high phosphate is a problem, because this high phosphate binds with calcium and causes calcium deposits in tissues that should not have calcium, like the brain, like the lens of the eye, and it can cause cataracts. It can deposit calcium and phosphate mineralization. We can see that in the basal ganglia. That can cause problems with the movement, may or may not be associated with that. We're trying to understand more about the relationship between basal ganglia calcification and brain function. And that's an area of active research right now, as well as the calcium phosphate deposits in the kidney. And we're understanding more about the effects of abnormal calcification in other tissues as well. But having a high phosphate is a problem, because phosphate will deposit with calcium in these other tissues that it should not be depositing. We will also have low 125D, so that our ability to absorb calcium and phosphate from the bowel is impaired, and that will also impact our ability to get calcium out of the bones. There will also be a decrease in the markers of bone remodeling. So the bone cells are removing and repairing the skeleton and removing old bone and replacing it with new healthy tissue. That's not happening in a normal fashion in people who have inadequate parathyroid function. And we see a reduction in the rate of bone removal and bone formation. And of course, we're going to see all this calcium being filtered through the kidney, and the urine calcium is going to be high. Now, it's important for our doctors to check all of these results. We don't just check calcium and PTH. We need to know, what is our phosphate doing? What is our magnesium doing? What is the urine calcium doing? Because all of these are going to be affected if we don't have normal parathyroid tissue. If someone has surgery on their neck, it could be because they had thyroid cancer and they had to have their thyroid gland removed, or they had parathyroid disease and they had parathyroid tissue removed, but the remaining parathyroid glands were damaged, then they can go on to develop post-surgical hypoparathyroidism. And that means that the parathyroid tissue, the remaining parathyroid tissue, was either damaged or the blood flow to the normal parathyroid tissue was damaged. And we say that if someone has a low calcium and an inappropriately normal or low PTH 12 months after surgery, then that would confirm that they have permanent hypoparathyroidism. So what are the causes of hypoparathyroidism? Well, surgical, post-surgical is 75%. And most of the people today here who have hypoparathyroidism, 3/4 have this because of surgery. A quarter will have this because of non-surgical causes. And this is where your doctor's expertise is critical, because your doctor will decide and determine why you have hypoparathyroidism. Is it because of autoimmune disease? And autoimmune disease could be alone, where just the parathyroid function is affected, or it could be in association with autoimmune polyendocrine syndrome, where we could have adrenal insufficiency. We might have candidal or fungal infections in the oral cavity. And there can be a number of other conditions associated with it. It could be because of infiltration of the parathyroid glands, because of granulomas, such as sarcoidosis. It could be because of cancer. Patients who've had leukemias or lymphomas or breast cancer might have cancer spread to the parathyroid tissues. It could be because the parathyroid tissue was radiated. It could be because of copper or iron or aluminum being deposited into the parathyroid glands. Or it could be because magnesium isn't normal. High magnesium can cause a problem, as can low magnesium. It could be because of a severe illness, and people in the ICU can have a transient reduction in parathyroid function. It could be because the tissue is resistant to the effect of PTH. It could be because the mother, when she was pregnant, had an overactive parathyroid gland, and therefore her blood calcium was high, and the baby was exposed to high blood calcium, so the baby's parathyroid glands never developed. And so now the baby is born without normal parathyroid function. And if we don't find any of these conditions present, then we would say, you know what? You have idiopathic hypoparathyroidism. It isn't because of surgery. It isn't because of any of these other known causes to man that can damage parathyroid function or prevent normal parathyroid glands to form and function. And then we would say you have idiopathic hypoparathyroidism. We don't know why you have this, but obviously we have to treat it. So when someone develops hypoparathyroidism, their blood calcium will go down, and the symptoms that they can have depends on how quickly that calcium falls. So if the calcium is coming down very, 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 very slowly, it will not have a significant impact because the patient has become accustomed to these symptoms and they will be able to tolerate that more easily. Today, I had a patient whose blood calcium was only 1.76 millimoles per liter, corrected, and we called him up and said, you have to go to Emerge. And he said, but I feel fine. So, you know, you can have a very gradual decline in blood calcium and not realize that you're in trouble. And then it could fall further and you could get breathing problems, laryngospasm, bronchospasm. The heart muscle needs calcium. You could go into heart failure. The electrical circuitry of the heart needs calcium. And there could be arrhythmias, and a person could die if the calcium is very low. And it can affect the brain function because our brain cells need calcium. So if we don't have adequate calcium, it can cause depression, it can cause anxiety, it can affect our memory, it can cause confusion, it can cause numbness and tingling and carpopedal spasm. And so it's absolutely critical for us to monitor calcium and for everybody with hypoparathyroidism to know the symptoms of hypocalcemia. You will know there, I'm getting these symptoms. I'm getting numbness and tingling in my face and hands. My muscles are going into cramps and I'm getting leg cramps. I better take an extra calcium and call my doctor, go to Emerge. Or if you have a lab requisition, we give all our patients a lab requisition. It says stat, calcium and albumin, phosphate, magnesium. And if they're not feeling well, we tell them, go to Emerge, get this blood work done right away. And so they, you know, we want that level to be checked right away if you're not feeling well. It's always better. Don't wait till you're in a dangerous situation. Go earlier. And when your doctor will examine you, there are features of hypocalcemia that we can see on examination. One of them is the Chvostek sign. And so we can tap the facial nerve and it comes out over here and just in front of the earlobe. And when we tap it, we see twitching of the facial muscles. And this is present in about 70% of people who have a low blood calcium. But about a quarter, up to a quarter of the normal population can also have this. Trousseau sign is when the doctor can elevate the blood pressure cuff. And if it's higher than systolic pressure for 3 minutes, the hand goes into contraction. And more than 90% of people with a low blood calcium will have this sign. And only 1% of the normal population will have this sign. So your doctor will look at these features on examination. Now, there was a very important systematic review that was done as part of the global guidelines. And we recommend checking blood calcium if someone has had neck surgery, post-total thyroidectomy. If the blood calcium is checked and the parathyroid hormone is checked 12 to 24 hours after surgery. And if it is low, then there's a much higher incidence of permanent hypoparathyroidism if it's less than 1.05 picomoles per liter. So we can see that if someone has hypoparathyroidism, they can have low calcium. And if they are treated with active vitamin D and calcium supplements, there can be situations where they can overshoot and their blood calcium can actually rise and they can have hypercalcemia. It can affect their quality of life. These fluctuations in serum calcium can affect quality of life. It can damage kidney function. It causes calcium loss through the kidney. It can result in hospitalization. Hyper and hypo, both are dangerous. It can cause calcium deposits in the brain and in the lens of the eye. And these are features, complications of hypoparathyroidism. And it can affect the quality of life. And we can see that people, if we look at kidney function, the black bars are normal and the gray bars are people with hypoparathyroidism. And how many people have decreased kidney function? Well, look at the gray bars. The people with hypoparathyroidism are more likely to have decreased kidney function than people who have normal parathyroid function, because there are other conditions that cause decreases in kidney function. As we get older, kidney function goes down. Diabetes is associated with impaired kidney function, as is high blood pressure. But at all ages, the people with hypoparathyroidism are more likely to have kidney function impairment than people with normal parathyroid function. And in Canada, we have a hypoparathyroidism registry, and we look to see how many of our patients have impaired kidney function, kidney stones, and calcium deposits in their brain. And we found that after surgery, post-surgical hypoparathyroidism, 27% have kidney calcinosis, nephrocalcinosis, or calcification in the kidney or kidney stones. And of the ones who were non-surgical, 17%. And how does that compare to the general population? Well, the kidney stones are seen in 8 to 10% of people in the general population. So patients with hypoparathyroidism are like 2 to 3 times more likely to have kidney stones. And what about calcium deposits in the brain? Well, in the general population, 1% might have that. But here we have 15% after surgery and 37%, like 1/3 had basal ganglia calcification. And we've seen more hospitalization in comparison to the general population, a higher incidence of kidney disease, cardiovascular disease, neuropsychiatric disease, infections, seizures, and cataracts. Remember, the immune cells also need calcium to function. And the bone is denser and is not being remodeled and repaired. But is it more likely to fracture? That is a question that still needs more research. And it's something that is being evaluated at this time. So how do we treat hypoparathyroidism? Well, we give back calcium because these patients are peeing out calcium through the kidney. They're not able to effectively absorb calcium, and they're not able to get the calcium out of their skeleton. So we have to give them calcium, and we give them calcium carbonate or calcium citrate, and we want that calcium to be taken with food. Why do we want to take the calcium with food? Because the food has phosphate in the meal, and when we take calcium with food, the calcium will bind to the phosphate and it will get eliminated through the stool. So if you take the calcium with your food multiple times during the day, then it will have 2 benefits. Not only will it elevate the blood calcium, but it will help to reduce phosphate. And we were talking about how this high phosphate is harmful because the high phosphate binds with calcium and causes calcium deposits in the brain and in the lens of the eye, and can contribute to calcification elsewhere, such as the kidneys. So we don't want our patients to have a high phosphate. And if our patients are taking a proton pump inhibitor, we recommend that they take calcium citrate because calcium carbonate is best absorbed in an acidic environment, and the proton pump inhibitor will prevent that from happening. We have to give vitamin D. We want to make sure that our patients have adequate vitamin D. And we have to give them active vitamin D because remember, parathyroid hormone is critical in the formation of active vitamin D. It takes 25D and enhances that activation to 125 hydroxy vitamin D, which is the active form of vitamin D. And there are 2 preparations that are available. In Canada, we have calcitriol and alpha calcidol. Alpha calcidol is half as potent as calcitriol. I never use alpha calcidol. And it can also contribute to toxicity, and it takes a longer time for the levels to come down. So, and it's not as potent. So you end up having to take more pills, and we don't want to keep popping pills all day long. So you want to take the drugs that are more potent and that are going to be more beneficial. Now, calcitriol has a half-life of 5 to 8 hours. that means it's going to be reduced in the bloodstream significantly in that time period. So it's best taken twice a day. And some patients that are referred to our center, they're taking like a huge dose, 1 microgram, take it first thing in the morning. That's not a good way to take it. Break it down into small doses and take it twice a day. So you might even be taking it 3 times a day. It depends on how much is required. But we start at 0.25 micrograms a day, and it should be ideally taken in divided doses. And we can also give thiazide diuretics. These are water pills that help us to reabsorb that calcium through the kidney. And they are valuable because they can help to reduce the calcium loss through the kidney. Now, there are limitations to conventional therapy. First of all, if you're taking, say, 1 gram of calcium 3 times a day, that's 2 pills, breakfast, lunch, and dinner. And if you're taking calcitriol, that's 6 pills right there. There's another 2 pills there. What if you take 3 pills of calcium at breakfast, lunch, and dinner? That's 9 pills a day. What if you take 4 at each meal? Because you need 2 grams 3 times a day. You know, the numbers of pills that our patients are actually asked to take is phenomenal. And it's not easy to remember to take that. What if you're working in the day? You have to remember it's lunchtime. I have to take all those pills. I have to pop those pills. So it's a large pill burden, and that's not easy to take. And if we're giving all this calcium, as we're elevating the blood calcium, the kidneys are not able to retain that calcium because we don't have PTH. So they're peeing out more calcium. And that's going to cause the deposits of calcium in the kidney to worsen. And it's going to hasten the decline of kidney function. And if we give lots of active vitamin D, remember I said that active vitamin D increases the absorption of calcium and phosphate? Well, if we give more vitamin D, active vitamin D, phosphate levels, which were already high, are going to go up even higher. So that's a problem because that will contribute to intracranial calcification, extraskeletal calcification. So conventional therapy has a lot of limitations. It's not the solution. And it results, we're not able to correct the problem. We're kind of backpedaling, trying to keep up because we're peeing out all this calcium through the kidney and we're having this high phosphate level, and we're just making the situation worse by giving all this calcium and active vitamin D. We need to give back the missing hormone. And this is where the research really has gone. And there are 2 hormones that are right now available in the world. In some parts of the world, we have recombinant human PTH 1 to 84, the full length molecule. This was approved by the FDA in 2015, but then it was withdrawn because of particles in the solution. And this is a molecule that has a 3-hour half-life, and it can certainly result in significant improvements in the symptoms, and it can improve serum calcium and reduce the pill burden. And in some studies, it has been shown to reduce urine calcium loss. We also have teriparatide 1 to 34, which is the first 34 amino acids of the parathyroid hormone. Its half-life is an hour. So if patients are taking PTH 1 to 34, because that's the only molecule available in some countries like Canada, then they have to take it twice a day or sometimes 3 times a day, because its half-life isn't long enough to provide protection throughout the day. PTH 1 to 84 is better because it's gone from 1 hour to 3 hours. So we did a big study looking at all the global literature, and we said we're going to compare PTH to standard of care, which is conventional therapy. And how does it compare? Where's the research? How does this match up to conventional therapy? And we looked at all of these studies, and what we found was that PTH 1 to 84 can be given in doses of 50 micrograms to 100 micrograms. And then this was studied in the REPLACE study in comparison to active vitamin D and calcium, and also patients were on active vitamin D and calcium and they were tapered down. And in this study, we saw that the serum calcium was maintained in the normal range and serum phosphorus went down, but there was a decline in the urine calcium, but it went down in both the PTH and the control groups, because these patients were very closely followed. And there were reductions in the active vitamin D and calcium supplements. And so we saw reductions in urine calcium in both groups, but there wasn't a difference between the two groups. And then there was another important study looking at this PTH 1 to 84, 100 micrograms a day. So this is marketed under the name of NatPara. And this was in comparison to active vitamin D. But in this study, 100 micrograms was added to active vitamin D and phosphorus levels came down, but there was no change in urine calcium. And then Karen Weiner did a number of important studies looking at synthetic PTH 1 to 34. PTH 1 to 34 is teriparatide, but this was synthetic PTH 1 to 34. And what she showed was that when we gave the PTH 1 to 34 in more frequent doses or as an infusion, then that urine calcium was able to go down. And when it was given as an infusion IV, then it actually resulted in a lower amount of PTH being required. And then we have another molecule called TransCon PTH. And TransCon PTH is PTH 1 to 34, which is teriparatide, and it's linked to a polyethylene glycol moiety, which is injected every day, and it gives this molecule a 60-hour half-life. So it's like an infusion, but you only take it once a day. And so in this study, and this was a global study, TransCon PTH was given in different doses in comparison to placebo. And in this study, we were able to show a reduction in urine calcium and maintenance of normal serum calcium. And then there's another phase 3 trial. And in this study, TransCon PTH was given in comparison to placebo, and 93% of people on this molecule were able to stop their active vitamin D and significantly reduce the calcium supplements, so it was less than 600 milligrams a day. And treatment with TransCon PTH normalized the urine calcium, the 24-hour urine calcium normalized, and there was a significant improvement in quality of life. So this is what this TransCon PTH looks like. So there's the PTH molecule. It's linked to this polyethylene glycol that surrounds it, so it prevents it from being broken down right away. And then when it's injected, it's this molecule is released, and there is a release of the TransCon PTH. So it's the PTH is released and it can go on and bind to its receptors. So it's like an infusion of PTH. And in this phase 3 study that has just been accepted now for publication and will be going online very soon, TransCon PTH 18 micrograms a day in comparison to placebo was given to patients. And at week 26, we looked at how many people were able to maintain the serum calcium in the normal range and come off their supplements and not require active vitamin D. And we were also looking at their quality of life. How were they feeling physically? How was their function mentally? How was their overall global impact on quality of life? And we were looking at important factors such as urine calcium. Are we able to reduce urine calcium? Because if we can't reduce urine calcium, we can't protect the kidney. Are we able to improve the quality of life? Are we making patients feel better? Are we reducing these wide fluctuations in serum calcium? And how the side effects? And what was seen was that 93% of people with TransCon PTH were able to achieve independence from conventional therapy. That means they were not taking any active vitamin D, and they were taking less than 600 milligrams of elemental calcium per day. So that's pretty impressive. And what happened to their blood calcium? These are the people on TransCon PTH. This is the placebo, and the placebo, they were on active vitamin D and calcium as well, because we can't take them off, otherwise they could die. So you can see that the blood calcium in the blue range, this is the blue range, is normal. So it was nicely in the middle of the normal reference range. And what about their symptoms? So the HPES symptom scale tells us what their symptoms are like. How bad are they feeling? Well, you can see that their symptoms went down very quickly when they started TransCon PTH, and they stayed down: physical, cognitive, and their overall daily life. And the placebo group, these are the ones who continued with their calcium and active vitamin D. There really wasn't any change in how they were feeling. But the ones who started the TransCon PTH had significant improvements in their symptoms. And we've had patients come back and, they've been so improved in their overall function that they've been able to do well at school, start new jobs. One of our patients began to build houses. He loved to do construction. Obviously, he couldn't do that with his hypoparathyroidism and the low blood calcium, even though he was on conventional therapy. But once he started TransCon PTH, he was building houses. One of our patients is a nurse, and she was on disability. But when she went on TransCon PTH, she went back to work. So it made huge differences. One patient could never come to see me because every time their appointment came up, they were in hospital with either a low calcium or a high calcium. We eventually were able to see this patient and start them on TransCon PTH, and they haven't been hospitalized since then. So these are life-changing situations. And it was really, really beautiful to be able to see the impact of these molecules on patients' well-being. And here we can also see their overall physical functioning. The SF-36 scale looks at how patients are feeling, their overall well-being. And people should be in this range, in between these two dotted line bars. And we can see over here that the patients with TransCon PTH were low before, and then with time, they got better and they got into the normal range. Whereas the placebo group, nothing happened to them. There was no good news for the people on placebo and their calcium and active vitamin D. And what about the urine calcium? Did it reduce the urine calcium? Yes. Here's the TransCon PTH, and we can see that from baseline to week 26, dramatic declines. The dotted lines are normal. So in the beginning, yeah, they were peeing out more calcium than they should have. The urine calcium was high, but look, at week 26, the urine calcium dropped, and there's placebo. So you can see that there was a significant improvement. There was a greater reduction in urine calcium on TransCon PTH than in those on placebo, and it was statistically very significant. And people will do well in a study even if they're not on the drug. The reason is that they're being closely monitored, and we're looking there at their levels, their blood calcium, the urine calcium. We're trying to refine their treatment, and that's why people do better in studies, because they're being so closely watched. And the drug was well tolerated with very few side effects. The side effects were injection site reactions, which were mild to moderate or possibly headaches. So in the systematic review, we saw that parathyroid hormone can be of great benefit to patients. And we made a recommendation in the global guidelines. And in the global guidelines, we said that conventional therapy should be the first line of therapy. We start off with conventional therapy. Some people don't need PTH because they might just need a small amount of calcitriol, maybe 0.25 micrograms. I have some patients who just take it 3 times a week, and they just take 1 calcium supplement a day, 500 milligrams at lunchtime. That's it. And so you can begin with first line therapy, conventional therapy, and then see what your patient's requirements are. And if patients are not doing well, consider parathyroid hormone. And we also said that it's important to make sure that our patients are not having symptomatic hypocalcemia. Correct that. If their calcium levels are low and they're having symptoms, that's not good. They're having brain fog, they're having muscle weakness, they're feeling tired, they have low quality of life, poor energy. We have to correct it, but we don't want that calcium to be high. And we don't want our patients to be having high urine calcium. We want to measure urine calcium and make sure it's normal. And that's an important point. We also want to make sure that phosphate is normal. Everyone should be having their phosphate measured. And I also advise my patients to take their calcium with food because it'll bind the phosphate that's in the food. And we tell them to go on a low phosphate diet. Phosphate is high in canned and boxed foods. And dairy products, unfortunately, are high in phosphate. So soy milk and the cashew milk, almond milk, these types of products are useful because they have calcium added to that drink, and they are low phosphate drinks. And hyperphosphatemia may be associated with increased risk of calcium deposits in the brain and in the eye and the kidney. And we also want to measure magnesium, and we want to measure vitamin D and normalize it. And if the urine calcium is high, then patients could be considered for a thiazide diuretic. And they could also be considered for PTH therapy if they're not doing well. If their symptoms are not being corrected, then we want to give them PTH therapy. If their phosphate levels are high, we want to give them PTH therapy. If they have kidney disease, we want to give them PTH therapy. If they have high urine calcium, we want to give them PTH therapy. Or if they have poor quality of life, we want to give them PTH therapy. So I also wanted to say something again, coming back to Bob and Patty's comments at the beginning. You know, we want to have hope. We want to normalize quality of life and improve the lives of people with hypoparathyroidism. And, you know, we've got really good molecules that are coming down the pipeline. And I just wanted to say a little bit more about this. The AZP 3601 is a long-acting PTH molecule, and this has been shown to improve serum calcium, and it has been well tolerated, and it can reduce urine calcium, and it's a very valuable molecule, which we're looking forward to seeing in clinical research. TransCon PTH is currently in phase 3 clinical trials, and we are expecting to have this available next year. That is the expectation, that this molecule will be fast-tracked and become available because our patients need it. Calcilytics are very, very interesting molecules. And just to show you how the calcium sensing receptor works. So this is a cartoon of the chief cell that sits in the parathyroid gland, and it has a little receptor on the surface. And calcium binds to the receptor and turns off the release of PTH. So when our blood calcium goes up, it binds this, there's more binding, and the chief cell says, oh, the calcium levels are going up, let's turn off PTH. And so PTH comes down. Now, what if this receptor is super sensitive? Because there's a mutation in the gene that regulates the formation of these calcium sensing receptors. And so the receptor is actually abnormal. And so if it's super sensitive, even though calcium is normal, it's turning off PTH. And that condition is called autosomal dominant hypocalcemia. It's because of a gain of function mutation in the calcium sensing receptor, and the receptors are super sensitive. And so the calcium is actually low and the PTH is low. And in the kidney, what happens is when calcium binds to the receptor in the kidney, it increases urine calcium. And it's because it's super sensitive, the urine calcium is very high. And people who have this condition are more likely to develop the renal complications of hypoparathyroidism. And so we have this new class of drugs called calcilytics, which block the calcium sensing receptor. And so that will result in a natural rise of our own endogenous PTH. And it can decrease the amount of calcium that is being released through the kidney. And there is a lot of good work happening in this area. And in patients who have autosomal dominant hypocalcemia, they can have a low serum calcium and a low PTH, and they can have elevations in urine calcium. And Keleret has been associated with improvements and normalization, that should say blood calcium, urine calcium, and PTH, and reductions in phosphate. And it was well tolerated with no serious adverse events. And I know that this is going to be presented, all of these, there'll be further presentations over the course of this exciting symposia that will provide you with more details. And the AZP3601 in a rodent molecule, this is a long-acting PTH-PTHRP. And this molecule has been associated with improvements in blood calcium. And if we look at the effect in rat studies, we've seen that it can preserve the skeletal strength. It will not damage the bone. So what are important features for the physician to consider in managing hypoparathyroidism? Number one, we don't want our patients to have symptoms from their hypocalcemia. Number two, we want to avoid hypercalcemia. Number three, we don't want the phosphate to be high. Number four, we want the vitamin D to be normal. Number five, we want magnesium to be normal. And number six, we want that calcium to be normal in the urine. And I'm going to just say, just in the interest of time, that in the new guidelines, we have also made recommendations for appropriate genetic testing to find out why our patient may have hypoparathyroidism. And we look to see if they have features of other diseases. And if they do, then we recommend a more detailed genetic analysis. And if it seems like the hypoparathyroidism is present in isolation, then we recommend a more limited genetic analysis, just evaluating these genes, these 5 genes that are going to be helpful in understanding why they have hypoparathyroidism. But to understand the genetic etiology is important because, as I've mentioned, for example, patients who have autosomal dominant hypocalcemia because of mutations in the calcium sensing receptor gene or the GNA11 gene will have a different manifestation than patients who have hypoparathyroidism due to, for example, a GATA3 mutation, where they also have deafness and renal impairment, or DiGeorge syndrome, where they might have cardiac abnormalities, palatal abnormalities, and other conditions. So it is important for your doctor to know why you have hypoparathyroidism. And there are DNA studies that can be done to find out why you have hypoparathyroidism. And it's important that this be evaluated. I just want to say a few words about pregnancy. And what happens in pregnancy in a patient who has hypoparathyroidism is the breast and the placenta produce a hormone called PTHRP. that can act like PTH. And it can help get calcium out of the bones. It can activate vitamin D. And so in pregnancy, a patient with hypoparathyroidism may not need as much calcium and active vitamin D. But your doctor won't know unless they're measuring your calcium levels very closely. Because remember, the baby's fetal skeleton is developing. And because the baby's fetal skeleton is developing, the calcium demands are higher in pregnancy. So will those demands, those increased demands, be met by the rises in PTHRP and active vitamin D? May or may not be the case. Some patients it will be enough, and there will not be a rise in the needs for calcium and active vitamin D. In some patients, it may be too much, and we might have to cut back the calcium and active vitamin D. And in other patients, it may still not be enough to meet the fetal requirements, and they will still need more calcium and active vitamin D. So what we're recommending for doctors is that we measure calcium every 3 to 4 weeks during pregnancy and lactation. It's very important that we're on top of the situation. And that means lots of visits to your endocrinologist. And the endocrinologist should work closely with the obstetrician and the pediatrician. And the drugs that are safe in pregnancy are calcium and active vitamin D, but it means a lot of visits. But if you do those visits, then you'll have a safe and healthy pregnancy, and you'll have a healthy baby. And so it's really, really important that if you are pregnant and you have hypoparathyroidism, please take this seriously and do your utmost to stay on top of your medications. It's not easy, but do your utmost to take your pills the way that your doctor thinks you're taking them, so that we can make adjustments in the amount of calcium and active vitamin D to meet your requirements. Because in pregnancy, having a high blood calcium is dangerous, because that will prevent the baby's parathyroid glands from developing. And having a low blood calcium is dangerous because it can cause premature labor, and you could lose your baby, you could have a miscarriage. Or if your blood calcium is low, the baby's parathyroid glands may become very large, and they could become so large that they could demineralize the baby's skeleton and cause fractures even before the baby's born. So if you are pregnant, please work very closely with your endocrinologist and have your blood calcium checked every 3 to 4 weeks, and follow up, call your doctor and say, do you want me to make any changes? Was my calcium okay? And our recommendation in pregnancy is that the calcium has to be corrected calcium for albumin or ionized calcium. It has to be mid-normal to lower normal, but never below normal. It has to be within that normal reference range. Absolutely critical. And we don't want patients who are pregnant to take thiazide diuretics. We don't want patients who are pregnant to take PTH analogs. So with that, I would like to thank you for your attention, and I'm happy to answer any questions.
All right. Yeah, we got quite a few questions. Thank you, Dr. Khan, for that. So like, we'll go with this first one. It says, for those of us that have been on that para for several years, 13 years, 6 on the pump and very stable, what treatment can we move into to give us the same life standard that we are accustomed to, normal kidney function with or without additional meds, no brain fog, physicality, able to perform sports, no tetany, no ups and downs, etc.?
So if that was achieved with pump therapy, then I think that you should stay on the pump until we have a long-acting PTH molecule available that can provide the same type of profile that we can see with a pump. And your best bet would be to wait until TransCon PTH becomes available, which will be hopefully next year.
Okay. Here's one that comes up quite a bit. It says, what do the missing 48 to 50 missing amino acids do for us that aren't in Forteo, Transcon, PTH, and Amylit AZP 360? In other words, the difference from the full amino acid chain, PTH 1 through 84 versus PTH 1 through 34. These missing amino acids, are in a normal body, they must be needed in us as well.
And that's a really good question. And we are doing more research to understand the full effects of the full hormone. And this is an area of research that requires greater understanding. But right now we know that the effects of the parathyroid hormone for the effects of the parathyroid hormone on the PTH receptor requires the first 1 to 34 amino acids. That's critical. What does the rest of the molecule do? It's still being evaluated. It's an area of research that needs further understanding.
Okay. Had another question come in. It's, what is considered high phosphorus? Mine is 6.5. Can I reduce it by diet? And what would you recommend?
Yeah. So the phosphate, it should be in the normal reference range. And in some countries use SI units, some countries use imperial. So based on the normal reference range at your lab, you want the phosphate to be in the normal reference range. And you can certainly make dietary changes. You can take calcium with your food. That will be a more effective binder of the phosphate in the food. You can go on a low phosphate diet. I tell my patients to avoid boxed foods, canned foods, and also to go on a low dairy diet and get the calcium from soy milk, preferably, and the nut milks. Those are also very good options for dietary calcium. And also, there may be a possibility of reducing the dose of the active vitamin D. So increasing the calcium supplement with meals, reducing the dose of the active vitamin D. And then we also have non-calcium phosphate binders, such as sevelamer, that can be helpful in patients who have very high levels of phosphate.
Okay. What levels do you believe are appropriate for vitamin D3 and then deactivated D125?
Right. So that's a really good question. And we recommend that the 25 hydroxy vitamin D be between 75 and 125 nanomoles per liter. And the active vitamin D should be normal as well. And you can measure those at your lab, and you can look at the normal reference range for whichever country you're in, if you're using SI or imperial units, and ensure that those values are normal. It is important to normalize those values.
Okay. Yes. Continuing with this subject, I have one, and it says, you said calcitriol is preferred to alpha calcidol.
Yes.
I've been taking alpha calcidol because I felt quite a big fluctuation when I tried calcitriol once. In this case, do you think it might be better to keep taking alpha calcidol or need to try calcitriol again?
If you're doing well on alpha calcidol, I would continue with the alpha calcidol. If your levels are stable, your phosphate isn't high, the urine calcium isn't high, and your blood calcium is in the low normal to slightly below normal reference range, you're not having symptoms, then I would stay with that. There's nothing wrong with it. If you've been able to achieve stability with it, then that's not a problem to continue.
Okay, so does low calcium affect sleep? I am struggling with sleep and waking up in the middle of the night. My endo now has me taking calcium around the time I am waking up, thinking it might be related to low calcium.
It certainly could be. It could be a factor. Low calcium can affect mood. It can affect anxiety. And it can have more significant effects, obviously, with seizures, but it could certainly be having an impact on sleep. And so trying to achieve a normal serum calcium may very well be of benefit.
Okay, and since some of these other therapies, there was a lot of split dosing and being able to use in a pump. So some of the questions are coming through specifically about Transcon PTH being able to use in a pump or being split dose. Have you seen any microdosing of TransCon PTH or pump use?
Yeah, so we have used it in a large number of patients in the phase 2 and the phase 3 trials. And the TransCon PTH has a half-life of 60 hours. So it doesn't need to be given more frequently than once a day. And it will stabilize the serum calcium. And there is a range. So you could go from 6 micrograms a day up to 60 micrograms a day. So there's a wide range. And some of our patients require very small amounts of TransCon PTH, and others are requiring the 60 micrograms a day. So there's a wide dose range, and its half-life is such that it does not need to be given more frequently than just one sub-Q needle. It does not need to be administered as an infusion. An infusion would be required for teriparatide, which has a half-life of an hour only.
Okay. So back to a pregnancy-related question. It says, so do I stop TransCon PTH if I get pregnant and go back to conventional therapy?
Yes, we would recommend that.
Okay. Can you talk about the antibody risk with PTH therapies and duration of effect?
Yeah. So patients may develop antibodies to PTH, and we have been looking at this. And with the PTH 1 to 84, the TransCon PTH, both of these molecules, we haven't seen any antibodies that would block the effect of the PTH. So we haven't seen neutralizing antibodies form that would have an impact on the function of the PTH in an individual patient. But patients could certainly develop antibodies.
Okay. A lot of good questions coming in. So I hope I'm pronouncing this right, liothyronine affect calcium levels because it speeds up metabolism more rapidly?
The thyroid function should be normal in an individual patient. So if a patient is on T4, T3, it is important for us to ensure that the thyroid function is in fact in the normal reference range, because that can have an impact on calcium requirements. Other drugs, for example, steroids, prednisone, for example, if a patient is on steroid replacement, if they have adrenal insufficiency because of APS1, then that can have an impact on the absorption of the calcium from the bowel. So it is important to discuss other concurrent therapy with your physician and ensure that the levels are appropriate and that your calcium and active vitamin D dose is appropriately being titrated.
Okay, we've probably got time for 2 more. So when is the best time to take active vitamin D? I take 3 milligrams of alpha calcidol split in 2, and 2 by 2 calcium pills together with the calcium pills or in between.
Right. So let's start with the calcium. So the calcium should be taken with food. And I tell my patients, every time you eat, take a calcium pill. And the larger your meal, the more calcium you should take with that. So if your biggest meal is lunch, then have a larger, like maybe have 2 calcium pills with lunch, maybe 1 with breakfast or 2 with breakfast if you're having a larger breakfast, and have 2 with dinner. So split your calcium so you take it with your meal. That will make it most effective in binding phosphate, and also will give you the calcium requirements that are needed. Alpha calcidol can be given twice a day if that's how you're taking it. Calcitriol can be given twice a day as well. It's best to give it in divided doses because its half-life is not that long. We're looking at 5 to 6 hours.
Okay, and the last one is it possible to get a copy of the new global guidelines, and where are they published at?
Yeah, so the new global guidelines are going to be published. They're actually online now, JBMR. And as soon as we get them, Bob, you are one of the authors on the evaluation management task force. And so we will have them, and they can certainly be posted on the Hypopara website. We will
Okay.
forward copies of all those papers to you guys, and we would welcome you posting them so that we can disseminate these widely.
Absolutely. We're going to do everything we can to help disseminate them. I guess we got a couple more minutes, I just found out. So what do you think, or what are your thoughts about slow release calcium?
Well, I feel that slow release calcium can be of value, but this requires further study. And I would say that measure your calcium levels, see how your response is, and ensure that your symptoms are being adequately treated.
Okay. And then can DNA testing be conducted during early stages of pregnancy to determine if fetus has inherited CASR mutation or other mutations?
Yeah, so the calcium sensing receptor mutations, first of all, if the mother has a mutation, then there is certainly a possibility that the baby can have it because it is autosomal dominant. And usually the testing is done right after birth.
Okay, and then do you think genetic testing would help with approval for PTH therapy for a patient?
I don't think that the genetic testing is required for drug therapy approval. The drug therapy approval is based on everybody's individual clinical picture. And so if a patient is not doing well, our guidelines clearly state that they need to be considered for parathyroid hormone therapy. And there is sufficient evidence in the guidelines to warrant a switch to parathyroid hormone therapy. So you don't need to have DNA analysis to get drug therapy approved, thankfully, because not everybody has access to DNA analysis. And there are many patients who have post-surgical hypoparathyroidism who need PTH and need high doses. So it's not a requirement. All you need is to confirm that you're not doing well with active vitamin D, or you have complications like a high phosphate, a high urine calcium, fluctuating serum calcium levels, symptomatic hypocalcemia. That's sufficient to get you onto PTH, and it should be covered.
Okay, and then this one is there's such a debate on normal vitamin D levels. I've been in the lower end of vitamin D levels for 20 years. I have complained of fatigue, and my endo insists vitamin D wouldn't affect my energy levels. In your opinion, could vitamin D levels of 16 to 20 nanograms per liter or ng per liter milliliter cause fatigue and brain fog?
Yeah, the levels, if they're low, they are suboptimal, and I would recommend that they be normalized. And I would definitely recommend that. And that was one of the recommendations of our guidelines. So you could show your endocrinologist the current recommendations and say that, I really want to normalize all of these parameters. All of these parameters need to be normal. And another benefit of having these guidelines is that these are guidelines that standardize care, and they will be of value in enhancing care for patients around the world. And we do want vitamin D levels to be normal. That was one of the recommendations of the global guidelines.
All right, well, that's going to wrap it up for time. And I want to thank everyone for the questions that you submitted, and hopefully we got them answered. If not, we'll try and get them back to Dr. Khan. I don't know why there's a brain fog. Holy cow. But yeah, we'll just go offline for a short break. We'll be back at 2:10 for the next session with an update on cartilage treatment for ADH1 and other forms of hypopara. And that's going to be with Dr. Gaffney and Kelly Roscoe. And again, I want to thank you, Dr. Khan, for all the work that you've done. And it was an absolute pleasure working with you and that esteemed panel of doctors as we develop these guidelines. And we cannot wait to get these released to the public. It's fantastic.
Thank you. Thank you so much, Bob, for your contributions, and to Patty as well, and all the organizers of the Hypoparathyroidism Association. It's truly been my pleasure. Thank you so much, guys.
Yeah, thank you.
Bye.